part 2 of the lecture on screening. In this lecture, we will be covering sensitivity, specificity, and predictive value. Validity of a screening test. Validity means to the extent to which the test measures what it's supposed to measure or what it purports to measure. It means that how correctly the test can identify those who actually have the disease and those who do not. Validity has two components: sensitivity and specificity. Evaluation of a screening test. Evaluation of a new screening test involves calculation of its sensitivity, specificity, and validity. How is it done? The test is applied to a group of patients who are diagnosed to be actually having the disease using a well-established diagnostic test. It is also applied to a group of people who have been declared free of the disease by the same diagnostic test. The results are then summarized in a table. The established diagnostic test used here is called as the gold standard. Gold standard is the best test available for the diagnosis of the disease at the time. This is the table where the results of the gold standard and the screening test are recorded. Results of the gold standard are whether the disease is present or absent. The results of the screening test are whether the patient is positive or negative for the disease. A patient who has the disease and is positive according to the screening test is a true positive, and a subject who is free of the disease but gives a positive in the screening test is a false positive. A subject who has the disease but is negative according to the screening test is a false negative. And a subject who does not have the disease and is negative according to the screening test is a true negative. A plus B are the total number of positives, and C plus D are the total number of negative. A plus C are the total number of patients or the total number of subjects having the disease, and B plus D are the total number of subjects not having the disease. A plus B plus C plus D are the total number of the study subjects. Evaluation of a screening test. After recording the results in the table, the following measures are used for evaluation: sensitivity, specificity, predictive value of a positive test, positive predictive value, or in short PPV, predictive value of a negative test, negative predictive value, or in short NPV, the percentage of false negatives and the percentage of false positives.
Sensitivity of the test. Sensitivity is defined as the ability of a test to correctly identify all those who have the disease. That is, the ability to pick out the patients as true positives. A test with 95% sensitivity would mean that it will pick up 95% of patients as positives, yet 5% of the patients will be missed out, and these will be the false negatives by the test. How to calculate sensitivity? We use the table that was explained previously. In this table, the formula of sensitivity is number of true positives divided by the number of patients diagnosed by the gold standards, patients with disease, into 100. So this will give number of true positives divided by the patients. So that will be number of true positives divided by true positives and false negatives. That makes it A divided by A plus C into 100. Clear? Sensitivity answers the following question, that is, what percentage of patients will be picked up by the test under evaluation? Second measure of the screening test is specificity. The definition of specificity is the ability of a test to correctly identify all those who do not have the disease. That is, the test is specific to the disease. If disease is not there, the test will not turn positive. In other words, ability of the test to identify non-diseased as true negatives. A test with 95% specificity would mean that 95% of the disease-free individuals will not be labeled as positive. Yet, 5% of the disease-free will wrongly be labeled as positives when actually they are not diseased. And these will be called as false positives. High specificity means that the test would not become positive in any condition other than the specific disease. Steps in calculation of specificity. We use the same table as discussed previously. Specificity is calculated as the number of true negatives divided by the total people who are free of the disease into 100. So that will be number of true negatives divided by true negatives plus false positives. That is D divided by B plus D into 100. Clear? Specificity answers the following question. What are the chances that the test will not report positive in any condition other than the disease it intends to diagnose? It is usually observed that a test which has high sensitivity has a lower specificity, and a highly specific test will have low sensitivity. A test which is highly sensitive will turn positive in every case of disease. That is, it is easily turned positive and hence may turn positive in some of the non-diseased cases also. So there will be some false positive as well. On the other hand, a highly specific test will not turn positive unless and until the disease is there. And as a difficult to turn positive test may remain negative in some of the mild cases of disease. So there is a high percentage of true negatives, but there is a high chances of having false negatives as well. So usually sensitivity and specificity have inverse relationship, but exceptions are there. Some tests may be high both on sensitivity as well as specificity. Can you think of some disease where you would prefer a very high sensitivity of the test? Even if it means some loss of specificity, it means you would not like to miss any case of the disease, even if it means some false positive cases, which later on may turn out to be disease free. One example of such disease would be a disease which has very high fatality if left untreated. In such a case, you would like to have a highly sensitive test so as to pick up all the diseased people and treat them in time, even if it means picking up some false positive subjects which later on turn out to be disease free. Similarly, can you think of some diseases where you would prefer a test with very high specificity, even if that means some loss of sensitivity? That is, if the test is positive, it should be true positive only. Otherwise, it should be negative. That means it will be less sensitive. It may miss out some mild cases. But if it is positive, we should be 100% sure that it is actually positive. One example of such a disease would be a disease associated with a lot of social stigma, like AIDS. Such a disease may lead to such a social upheaval in the patient's life that some people have even tried to end their lives. So, before declaring a person as positive, you would like to be very sure that he actually is positive. Hence, in such a case, you will need a test which has very high specificity. Predictive value of a positive test or positive predictive value. It is the probability of actually having the disease when the test result is positive. Predictive value measures the diagnostic power of the test. For example, if a test has a positive predictive value of 99%, it means that if the test result is positive, it is 99% sure that the subject actually has the disease. Positive predictive value is calculated as number of true positives divided by number of true positives divided by total number of positives into 100. That is number of true positives divided by true positives plus false positives into 100. That is A divided by A plus B into 100. Positive predictive value answers the following question. If you have a test report that is positive, what are the chances that you actually have the disease? Predictive value of a negative test or negative predictive value. It is the probability of actually not having the disease when the test is negative. Predictive value is the measure of the diagnostic power of the test. A test whose negative result has a predictive value of 99%. It means that if the test result is negative, one can rest assured that 99% chances are the subject actually does not have the disease. Negative predictive value is calculated as number of true negatives divided by total number of negative results into 100 for percentage. That is number of true negatives divided by false negatives and true negatives into 100. That is D divided by C plus D into 100. Negative predictive value answers the following question. If the report of a test is negative, what are the chances that the individual actually is free from the disease? Predictive value of a screening test, that is predictive value of a positive test and predictive value of a negative test, depends upon the sensitivity, specificity, and the prevalence of the disease in the population studied. Prevalence. A higher prevalence will increase the positive predictive value and decrease the negative predictive value, and a lower prevalence will increase the negative predictive value and decrease the positive predictive value. Let's take an example. In a country where Ebola epidemic is going on in Africa, a person with symptoms of the disease has a positive result for Ebola. So there's a high chance that person actually has the disease, and we accept the positive report in the first instance itself. So there's a high positive predictive value. The same test is reported to be positive on a person in a remote village in India where no epidemic has been reported. One will tend to think that there is something wrong with the result, it cannot be positive, and would like to repeat the test. So the positive predictive value of the test in that village will be lower because the prevalence is so low that the positive value is taken to be questionable. So a higher prevalence will increase the positive predictive value and decrease the negative predictive value, and a lower prevalence will increase the value of a negative test and decrease the value of a positive test. Effect of disease prevalence on these values. Sensitivity and specificity are both independent of the prevalence of the disease. They are attributes of the test as such, and they describe how well the new test performs against the gold standard. So the sensitivity and specificity of the same test will remain the same in different populations, whereas the positive predictive value and the negative predictive value are dependent upon the prevalence of the studied population. That is, they are population specific. The predictive values will change for the same test in different populations.